It's a great pleasure to me to be here in this great group. Thank you very much, Nidhi, for inviting me. Today, I am going to talk about medical therapy for endothelium disorders. I will start about talking about ROCK inhibitors. As you know, ROCK functions as an effector molecular of the ROA signaling with important roles in regulation cell morphology, motility, and polarity via its rearranging effects on the actomyosin cytoskeleton. Specifically, activation of ROCK leads to formation of actin stress fibers, increased cell-cell junctions, as well as increased cell extracellular matrix interactions. The raw ROCK pathway has therefore an influence on various important cellular functions, such as maintaining cell shape, motility, adhesion, proliferation, and apoptosis of the cells. As you can see here, ROCK has been researched as a potential therapeutic target for vascular disease, cancer, neuronal degenerative disease, asthma, and glaucoma. Only 3 drugs have been approved for clinical use: fasudil, ripasudil, and netazurdil. The fasudil is approved for the treatment of cerebral vasospasm in Japan and China since 1995. Ripasudil, it is approved for the use in glaucoma or reducing intraocular pressure in Japan since 2014. And the last one approved was netazurdil in the United States in 2017. As you know, ripasudil administered twice daily has been proven to lower intraocular pressure by altering cytoskeletal contraction of the trabecular meshwork and Schlemm's canal cells, increasing this way the outflow facility of aqueous humor. Ripasudil is a highly selective for both ROCK1 and ROCK2 with minimal off-target effects as a result. Its safety was demonstrated in phase 3 clinical trials for ocular hypertension, and the main adverse event recorded was conjunctival hyperemia in 70% of the cases. As you can see here in this slide, mostly due to protrusion formation along intracellular borders caused by the reduction in actomyosin contractility of the cornea endothelium cells, as you can see in this picture. It is very important for the physicians that are starting to use these kind of drugs that should appreciate that ROCK inhibitors can cause these goutte-like findings in order to avoid misdiagnosing patients as having Fuchs endothelial corneal dystrophy. The ROCK inhibition as a potential promoter of cornea endothelium healing has been promoted and pioneered in recent years by Professor Kinoshita. Here in South America, it is currently out of label. We cannot use these kind of drugs. As you know, the cornea endothelium is a monolayer of cells which is formed from neural crest-derived cells. During development, human cornea endothelium cells proliferate and migrate centrally to form a continuous mosaic of cells facing the aqueous humor. Cell-cell contact induces growth arrest in J1 phase through contact inhibition mechanism, leading to the formation of a monolayer This is a recent study demonstrate that a few proliferation cells were found exclusively in the extreme periphery of the endothelium of human cornea with a short post-mortem time, and that a very slow and continuous centripetal cell migration might exist to partially compensate the physiological cell loss in vivo. this intervention of these cells, the intervention of these cells could regenerate a person's own endothelium cells, even in cases of FUCs, as an alternative to transplantation cornea from a donor.
Yeah.
This concept is very important in our practice. The doctors who are doing endothelium keratoplasty, we all know that when we have the endothelium cell density, when we have good endothelium cell density in the periphery, we are going to do small grafts. And when the periphery is not so good, we are going to choose big grafts. Professor Kinoshita, in this study, he demonstrated that the ROCK inhibitor improves culture efficacy in primary monkeys' cornea endothelium cells, increased frequency of proliferation in monkey cornea endothelium cells, and promotes wound healing in rabbits and in monkeys. Cellular stresses to the corneal endothelium activate ROCK MLS phosphorylation, which induce the loss of cell adhesion and promotes apoptosis of the cells. The ROCK inhibition was proved to suppress these chains of events and prevent apoptosis in these kind of cells. In this study, the study is very important because they demonstrate for the first time that the ROCK inhibitor is not toxic, does not induce proliferation, and does not modulate apoptosis. Treatment with ROCK inhibitor could not overcome antiproliferative mechanisms induced by contact inhibition ex vivo. However, it promotes cornea endothelium wound healing by engaging endothelium remodeling, adhesion, and cell migration. As you can see in this slide, we all know that ROCK inhibitors promotes ex vivo wound healing, induce a totally wound closure after 12 or between 12 and 24 days, while acellular areas could be still observed in the control group, as shown in this in the left picture. Okay, here so Roberto Pineda talks about the DCO. This study is very interesting of Gregory Moloney. He chose 12 eyes with central gutae and healthy periphery to combine these treatments. He have done a central desematorrhexis under viscoelastic, as shown Roberto. They not exceed 4 millimeters diameter, and they use ROCK inhibitors 6 times a day. The results were very good. They have 9 of 12 eyes spontaneous cornea clearance in the first 6 months. Okay, here you can see that they do not need to use the ROCK inhibitor for more than 2 weeks, and confocal demonstrate stable hexagonality cells. As you can see here in this study, the observation of the possible mitotic bodies on confocal scanning may indicate that some cells division is stimulated by the removal of cell-cell contact inhibition. The downward trends in cell counts, however, would suggest that it is still cell migration that is chiefly responsible for healing in these cases. Another of ROCK inhibitors and DCO, you can see in the pictures of the specular micrographs that in the case when they're used combined with ripasudil is better than in the micrographs that they don't use the ripasudil. Here you can see this study that it was done in the Veneto Eye Bank in the north of Italy. The purpose of this study was to investigate if the peripheral cornea endothelium that was discarded after the preparation of preloaded DMEC could be successfully used for cornea endothelium cell culture. These are the outcomes in these pictures. You can see in the left one, you can see the immunostaining and expression is very similar in the complete endothelium compared with the peripheral endothelium. In the other picture, you can see that the morphological analysis is very similar in the complete endothelium and in the peripheral endothelium. Here you can see in chart A, the confluence rates comparing the peripheral and the complete endothelium are very similar. In the chart B, you can see the difference in cells areas. In chart C, the hexagonality and the polymorphism is in both groups are very similar. And in chart D, you can see that the Ki67 positivity compared between both groups is better in the peripheral endothelium. So to finish the conclusions, you know that the pharmacological approach to the cornea endothelium cells recovery is very attractive. The inhibition of the raw ROCK signaling by the specific ROCK inhibitor was proven to promote cornea endothelium cells proliferation and wound healing. This kind of therapy is not toxic to the human eyes. DWEC cases may be candidates, and long-term effects is still remaining a question. Cell regeneration is going to be the future. Personally, I think that cell regeneration and the ROCK inhibitors are going to be the future of the cornea endothelium disorders combined with our actually endothelium keratoplasty. I think that in the next few years, we are going to combine these new therapies with the old therapies that we have today. Thank you very much.